Welcome back to the morning show here on Arise News. I'm Afolabi.
I'm Tundra Abiola.
I'm Veronica Adeka.
Childbearing is taken to be a theme of great joy to every woman. In Nigeria, which is an integral part of the larger African setting, motherhood is highly celebrated. But while this journey is easy for some women, it comes with a whole lot of challenges for others because of complications usually associated with the process of conception and giving birth. To help us bring some more perspective on this, we're now joined by Professor Bose Afolabi of the College of Medicine, University of Lagos. She's a professor of obstetric and gynecology with subspecialty in maternal medicine, the very same area that focuses on the treatment of pregnant women with different disorders, including sickle cell disease. Professor, welcome to the show.
Thank you.
Good to have you.
Thank you for having me.
Thank you. It's so exciting when I found out that you were coming to the show. I was very excited because of the work you're doing, and the work you're doing especially when it comes to maternal care. Nigeria has one of the highest rates of maternal mortality. Bill Gates was here last year, and he said Nigeria is one of the most dangerous places for a woman to have a child. These are very sobering numbers. About 2 weeks ago, we had the Minister of Labor say there were more doctors than we need, but data tells us that actually there's only one ObGyn for every 181,000 women. So these numbers are so disheartening, and also every woman knows someone that has died during childbirth. So as someone that works with women and actually has a special focus on sickle cell anemia, do you see the tide turning? What is how are we turning these numbers around?
Thank you for that question. It's not easy, but, and you've already alluded to the fact that there are not enough doctors, and including gynecologists. Mm-hmm. But one thing we have learned in the College of Medicine and Luth is the teaching hospital of the College of Medicine, where I work, is that when we individualize care and we pay a lot of attention to detail, it does make a difference. Sometimes, unfortunately, women come in when they have been elsewhere and they are really bad, and it's tough, it's difficult to be able to save them because they are already close to, they've been in extremis before they get to us. But apart from the ones who book with us and those that come in when we can still save them, paying attention to detail, making sure we assess their vital signs, every hour on the hour, and, really get all the treatment they need as quickly as possible, does tend to make a difference. And also because we're trained in emergency obstetric care. Part of the problem with, a lot of these maternal deaths is that a lot of women do not deliver under skilled health care. And like you said, childbirth is easy for a lot of people. However, there are a lot of complications that can occur, and it's difficult to predict those who will get those complications. Those are some of the problems, which is why it's advocated that every single woman should deliver with skilled health care, and that's usually in a hospital or in a place where, a maternity center at the very least, with people who have been trained how to deliver women safely or refer as appropriate.
So is this going to be, this topic, is it going to form a part of your inaugural lecture that you're preparing? Yes,
to an extent. So I will talk about maternal mortality briefly, and then I'll also talk about all my research on maternal medicine disorders, which include things like preeclampsia, diabetes in pregnancy, sickle cell anemia in pregnancy, how women are delivered safely, the types of anesthesia used, and so on and so forth.
Can you tell us more about the Maternal and Reproductive Health Collective Research Group that you have?
Okay, so that's just a non-governmental organization that I started with some of my colleagues, also in the College of Medicine. And what we've tried to do over the years is different things, including cervical cancer screening, getting funds for indigent patients. That's what we're actually focused on more now. Because there's a lot of patients who can't pay, or who, at least when they come into hospital, find it difficult to even get funds to start their care. In Luth, we do, take care of them for the first 24 hours and stabilize them. But sometimes by the time they are to be discharged, they haven't been able to pay, get money for their tests when they're more stable. So we try to get funds for such people, and that's been one of our major areas at the moment. We've done some research as well into reproductive health care.
You know, you mentioned a couple of things, which was the skilled care and, you know, the nature of how women who go and give birth need to ensure that they're going to hospitals where there's skilled care being provided. But I have recently understood that there are a lot of women, especially first-time mothers, that are in hospitals where there is skilled care being provided and still end up losing their babies. A lot of times, sometimes it is things out of their own care, but one of the things I have heard is a lot of times the cord for the baby is wrapped around the neck and the mother is being told by the doctor to either go home or wait for a few more weeks to be full term. Where what I'm trying to say is that most countries, some other countries, if it's a first-time doctor who's really understands the mothering process, will check the baby and advise the mother to go ahead and give birth probably a little earlier. But I've realized that in Nigeria as a whole, most doctors do advise their patients to wait until the mother is almost 10 months, whether 40 weeks plus to give birth. Do you think that this is a cultural way to think? Do you think that there's a mind shift that needs to happen? Or in your opinion and with your expertise, you feel that it's actually okay?
First of all, the information about most doctors, as in, I trust you mean most ObGYNs.
Yes.
Telling their patients to wait till 40 weeks or till 10 months is actually not accurate, let me put it that way, because it really does depend on how you assess the pregnant woman. There are a lot of different tools that we use to assess pregnant women, particularly to listen to the baby's heartbeat. There's some very old-fashioned ones which do the trick, which we use sometimes when in large places where we have a lot of patients. There are also some that use electronic fetal Doppler. But whichever one it is that you use, you can assess and monitor the baby properly. And if you do, and it appears that the baby is not doing well, or you do an ultrasound scan and the blood flow to the baby is not flowing properly, then you will deliver. You're not going to wait until 40 weeks. What I think you might be alluding to is that premature babies don't do as well. And so sometimes we want the baby to stay in longer, because the more mature the baby gets within the uterus, the more likely it is to survive when it's born. However, if we weigh both areas and we realize that it's safer for that baby to come out than remain in the dangerous environment of the uterus at that point in time, then we would definitely advocate delivery. One of the problems as well is that a lot of women are frightened about having cesarean sections.
Yes.
That is understandable. Everyone is afraid of surgery to an extent. But if we counsel them properly and we let them realize that, look, this is not death's door. The fact that you're having a baby with an operation does not make you any less the baby's mother, and also let the people around know more that, you know, cesarean section is a necessary thing for some people, then they should be able to take that. So it's not correct that a lot of doctors tell people to wait. We do, deliver as necessary. If the baby needs to come out, it needs to come out earlier.
Yeah.
I want to go to sickle cell, because I know a lot of your work is also around sickle cell and women that are pregnant with sickle, that have sickle cell. One of the things that came across literally as I was preparing for this, just very randomly, was an American black doctor who actually happens to be of Nigerian descent. She posted something, and I just want to read it to you. She said, both sickle cell disease and hemophilia are inherited diseases. Sickle cell anemia affects 100,000 people in America, mostly black in the U.S. Hemophilia affects 20,000 people, mostly white men. There are 2 FDA-approved drugs for sickle cell and 28 approved drugs for hemophilia. Someone who studied sickle cell, you've been all over the world studying sickle cell, you do a lot of work with women with sickle cell. Why is there just not enough research and drugs around sickle cell?
Yeah, I mean, the bottom line is that it doesn't affect Caucasians. Period. And a lot of the research funding comes from,
those
richer countries. Yeah, that's the unfortunate thing. As it is now, my doctorate in sickle cell disease, I was lucky to get a bit of funding from the University of Lagos to do some of the research. But that everything else I had to do myself. So, and a lot of research that we tend to do ourselves. Now, the National Institute of Health in the US, their budget is about probably the size of the budget of Nigeria or something equally ridiculous, you know. So, and that's the institute that funds research, you know, in the US. So a lot of it is to do with the fact that there isn't enough funding for research or for anything basically in the country, and it shouldn't just be left to government. I think that basically society too has to contribute. One of the things I plan to say during my inaugural is that people need to learn to give more. You know, people donate to institutions in these richer countries. Yes, the government does some, but a lot of people leave things behind. The Harvards, the Stanfords, all those universities have endowments. People give money to institutions for research, for care, for, you know, so many different things. Individuals also do their bits. So I think we need to have more of a giving culture, and of course the government also needs to pay a lot of attention to funding good research. It's easy to determine who's going to do research. You usually have to put in a proposal before you can apply for a research grant from these countries. I'm part of a research collaboration at the moment, and we have these grants we have on. It takes a lot. It's almost like applying for a bank loan. You know, you have to put in a lot of detail and, you know, so on and so forth, and really, really work hard. But, I mean, once you can prove that the research you're about to do is good quality research and is going to make good impact, then you will get your research grant eventually. So we should be able to have such, you know, what's the word now? Such grants that you would have criteria for people, you know, doing good research, and award research grants to people here so that we can develop things more. It's happening more and more, but it needs to happen a lot more.
And then with the woman that you take care of with sickle cell, what are the things that you're looking out for, and how do you manage that care when you know you have sickle cell and you're pregnant? What do women need to do first? Okay,
first of all, they need to come to hospital early. That is very important. In Nigeria, a lot of women come to book for their pregnancies late. When we say book, we mean register for their pregnancies. They come quite late.
Like how late?
When they're about maybe 5 months down the line is the average time that they tend to come. They should come in earlier, and particularly women with sickle cell disorder need to come in even earlier, by maybe soon after missing their period, because we need to let them know that pregnancy tends to cause a bit more problems. So they get crises when they're deprived of oxygen, when it's too cold, when they have infections, but they also get more crises during pregnancy. I think because of the demand of pregnancy, there's a lot of metabolic demand because of the growing fetus. So all the organs need more, you know, blood perfusion and so on. And for that reason, sickle cell disease women would, you know, tend to have more crises because of that higher demand. So they need to book early and be advised on what to do, including drinking a lot of water throughout. And anytime they have any pains, their usual bone pains, they should come to hospital earlier than they would have normally. And also make sure they're not too hot or too cold, you know, because those things also affect these issues. And from time to time, we see them more frequently as well during pregnancy. If they have any problems at all, we address it quickly, we hydrate them, give them good pain relief, and we treat their infections as necessary. So with that, you know, greater attention to detail, seeing them more frequently, making sure all the doctors know once a woman with sickle cell comes in to the hospital for admission in pregnancy, you know, we all gather together, make sure we get them good, quick care. We do tend to have very positive results.
And during delivery, how do we
deliver? Well, it's advocated that normal delivery, normal vaginal delivery is still the best bet, unless there's a particular obstetric reason. By obstetric reason, I mean things like, okay, so if she has a breech presentation, for example, that is the baby coming with the buttocks first, we would want to deliver by cesarean section, especially if it's the first pregnancy, or if she has a pelvis that is not big enough that we've assessed as not to be big enough for whatever reason. Sometimes they've had fractures of the hip, you know, growing up. So sometimes they would have to have a cesarean section. So for obstetric reasons, we would want to deliver them by cesarean section, but otherwise we try and deliver them vaginally, because that is actually safer.
So on a more personal note, Biana referred to the comments by the Minister for Labour, Dr. Christine Gige, saying that we have a surplus of doctors in Nigeria, which has since been debunked by, on several quarters. What made you return after your sojourn in the United Kingdom? Why did you come back to Nigeria? And we're interested in hearing more about the program that you're launching.
That my return is a very long time ago.
But most people go and they stay gone.
Yeah.
They never come back. Why did you come back?
I've just always had this, we are the only ones that can fix Nigeria type of mentality. And whether or not it's easy is a different thing. This is where I fit in. This is where I can make a difference. This is where, I'm needed more than the richer countries where they've made a lot of advancements and don't need the extra hard work. Exactly. That's how I feel. And I also don't like the cold much.
What about your launch? Tell us about your event.
Yes, my inaugural lecture is coming up in a few days' time on Wednesday. It's something to do with talking about my work, mostly research work, but also some of my clinical work. I've published over 50 publications in research journals and in textbooks. And so I'm going to talk about the salient ones. I'm also going to talk about my doctoral thesis in sickle cell pregnancy and but I'm going to break it down so that the public can also understand what I'm trying to say. So, yeah, I'm looking forward to it. It's a chronicle of one's career, basically. Although I still have, a long way to go, but for now, because I've become a professor, I'm supposed to talk about what I have done, up to that stage. So that's what it's going to be about.
All right, Professor, once again, thank you so much for being here. However, I'm going to be selfish here and ask you a very selfish question, and I know people do that all the time. One of the things that almost so many women in Nigeria have to deal with is fibroids. I mean, it's also something that a lot of Black women have to deal with. One of the things people do is get fibroid surgery. Can you tell us sort of what happens after surgery and how often the reoccurrence happens, or what happens after you've had surgery? Okay,
so it really differs in different women. Some people have fibroids that they start growing their fibroids very early. So you sometimes have, early 20s, mid-20s, year-old women having fibroids. And so some of them grow their fibroids quite rapidly as well. So the more that happens, those are the ones that are more likely to recur in our experience. But some people grow them much more slowly. Okay. So you may get to your 40s and just have a few small fibroids, So if you have symptoms at that stage and the fibroids are removed, it's not likely to recur that quickly because your own genetic tendency seems to be less. Okay. This is not fully evidence-based, but that is what we've seen in our experience. Now, when it comes to fibroid surgery and after fibroid surgery, oftentimes, some fibroids don't necessarily make people infertile. So you can have fibroids and still be able to get pregnant. But sometimes for people who have not been able to get pregnant because they have fibroids, when we remove the fibroids, they tend to be able to get pregnant afterwards. It also helps with IVF success, that is in vitro fertilization success, if you remove the fibroids. Unfortunately, some people that grow their fibroids quite rapidly, even when you take out the fibroids, within 1 to 2 years, they're starting to grow them again. Wow. So what we try and say then is to say, as soon as we've done the fibroid surgery, try to get pregnant then if you do plan to get pregnant so that you can complete your family. And when you're getting pregnant, they sometimes grow as well, but not necessarily as rapidly. It's a bit difficult to predict. It's just by individual, yeah.
Well, thank you so much for being here. We wish you all the best, and we hope you'll come back and join us again.
I hope so. Thank you. It's been a good